on, everybody? Welcome back to another episode of the Core Consults RX podcast. And guess what, Cole?
What?
Our buddy AJ, he has returned.
Oh, there he is.
The prodigal son.
I'm back.
It's only been like 3 episodes.
I feel like it's been a long time. AJ,
It feels forever.
yeah, I was going to say, it feels like it's been a minute.
Is this the first time I've seen you in 2023?
Maybe.
No.
Yeah, I think-
Couldn't have been.
Really?
No, I've been, no.
You've been back in January.
Yeah.
We'll have to consult the previous episodes because I don't remember.
Somebody knows.
But AJ, good to have you back, man.
Good to be back.
So we're going to be doing, I guess, kind of a weird episode tonight.
Smorgasbord.
This is more of a...
It's a topical
It's a
episode.
new theme we're doing. It's called Hot Topics that we happen to look up today.
Well, was that our patient case? And
Yeah, and we opted.
Either one's good,
We
but-
opted for this because we haven't done something like this yet.
Yeah.
So we're going to basically touch on a few different things that have been in at least the Medscape news and other, those things that come out to your email so you can stay up to date.
It's mainly that no individual one of these would have been long enough for a full episode.
Right.
So that's why it's...
if you want to boil it down to its most basic form, yes, that's the real reason we're doing it this way. But so we're going to be talking about the new blood pressure guideline that came out from the American Academy of Family Physicians, because it's a little bit different than basically all the other, except for maybe the European guidelines. Pretty much all the other guidelines are slightly different blood pressure goals than this one. So we'll kind of discuss that, and then we're going to talk about something that's been in the news lately called Ozempic Face.
Yeah, had you heard about that before today?
Yeah,
I had to.
I'd seen a bunch of stuff about that. People were like, "That's why you can't be taking this stuff."
Mm-hmm.
It's like, well,
We'll dispel the myths.
do more looking.
Yeah.
But and then Cole's going to wrap us up with another hot topic that
Yeah.
I don't know anything about, so we're really banking on him to sell at the last moment.
Well, it turns out that potatoes might not be as bad as you think.
Yeah. What's interesting about that is I don't feel like I ever was like, potato. You can't.
Well,
have potatoes.
if you think about all the different things that I'll say it for them. But if you think about all the different things you use potatoes for, in general, we would consider it pretty starchy, and we would consider potato chips or fries other things unhealthy. I'm not saying whether it is or isn't. I'm just going to tell you what this article says.
We're gonna leave people hanging to the end of the episode.
I gotta wait till the end.
So
I don't know what AJ said.
AJ we have a new thing where AJ just shouts out random words throughout the
Use
episode.
potatoes for vodka.
Oh, gotcha.
yes,
Vodka.
yes.
I don't know what you said.
It's terrible for you.
Yeah.
All right, so
Low in calories though, right?
there you go. And carbohydrates if it's straight, right?
I think.
Pretty much. Yeah.
Hepatotoxic, though.
Well, that is true.
There's that piece, yeah.
There is that. So I guess we'll start off with the one that's actually more clinically relevant, I guess. I don't know if we're going to consider it that way, but probably compared to our other two topics.
I don't know. The potatoes, we'll see.
Okay, that's a good point.
I read the whole article. I'm actually very interested in
That's
it.
pretty funny.
Yeah.
I'm glad you did because I definitely skipped that one. I was like, I'm going to do 2 out of 3. That's pretty good. But so the American Academy of Family Physicians basically released in December a new blood pressure management guideline and gave a little bit different goal blood pressures than are in the majority of the other guidelines that are available currently.
Yeah.
What was your first thoughts, Cole?
Well, traditionally the American Academy of Family Physicians is a little more, what's the word, conservative with this. I think they're also more conservative with A1C recommendations, or at least more conservative than some.
Relaxed then, because conservative makes it sound like it's strict.
You're right. Yes. Relaxed. So they're a little more relaxed with blood pressure.
Chill. They're like the cool, chill,
like the cool guys. They're like,
cousin.
Yeah, we're just primary care. We keep it real, and then we send it to the specialist to get into the nitty gritty.
Don't let them hear you say that. They're gonna be very offended.
It's not true. But they're a little more relaxed with blood pressure. A little more relaxed with
American College of Physicians is like that too. I feel like where they're like A1C goals are more relaxed. They tend to be more so than like the ADA. Anyways,
I wonder what that is. Anyways, that my first response was like, oh, they updated it a little bit. So they traditionally have been more in line with the JNC8 recommendations from almost a decade ago. Yeah.
2014, geez.
But now they've updated to be not quite in line, but a little more in line with some of the more mainstream guidelines on blood pressure.
Yeah, and basically their kind of summary is that patients who are that are with or without cardiovascular disease. So it's not even a difference between patients who are primary versus secondary or risk stratification, but patients that are adults that need blood pressure management should shoot for a goal of less than 140 over 90, pretty much across the board. And the patients who, maybe can tolerate it to cautiously maybe consider a goal of less than 138 or 135 over 95 or over 85.
Yeah. Which is the first time we've seen the fives pop in. It's
yeah.
the only one. It's like, no,
they're like, no, we're not going to comply.
We're not going to do 130 over 80 because that's what everybody else is doing.
Yeah,
we're going to be different.
We're like odd numbers.
We're going to do 135 over 85.
So, but they also immediately follow that up with, but you need to let patients know that there's going to be a lot more side effects with
caveats.
It. And I'm like, well, so yeah, I don't know. So it is, I guess all this started because JNC8, like Cole was saying, kind of had that patients under 60 were going to be less than 140 over 90, and then those that were over 60 could be less than 150 over 90. But then it all changed in 2017 is when the guidelines updated from the American Heart Association, where they started doing more strict blood pressure goals. We started getting the 130 over 80 goal, and a lot of that was based on the SPRINT trial results. And so patients in that study obviously included patients that had either had atherosclerotic cardiovascular disease or at least had a high risk for it. And when they had a more strict blood pressure control, they ended up getting more positive outcomes. And then a lot of the other major guidelines followed suit after the American Heart Association guidelines came out. So the big, I think, initial push, which this happened right away when these guidelines came out, was that, okay, well now, every single person is now going to be labeled as having hypertension and needing to take more medications, which means we're going to have, way more adverse effects, which they did have more adverse effects in the SPRINT trial and the stricter blood pressure goal arm as well. But I feel like they put such a huge kind of emphasis on the adverse effects. And especially looking at the literature coming from the new guidelines that were just published in December, they kind of basically say that when they did their literature review, that the trials on average were 3.7 years in length. About 75% of the patients in those trials did not have pre-existing cardiovascular disease, and that basically there was no statistically significant decrease in total mortality. And in regard to serious adverse effects, it was a higher risk with the more strict blood pressure goals. So because of that, they're saying that there would be no benefit in pushing patients lower, especially patients who were maybe less or at less risk of having a bad event in the first place. So they're a little bit healthier patients.
Right. Yeah. And so JNC8 before, so this isn't a huge change. JNC8 before would say 140 over 90 for patients under 60, but in the more elderly patients, they left it at 150 over 90. So yeah, like Mike said, the two real differences are 140 over 90 in some and 135 over 85. The reason they stratify this, so they give what would be considered a strong level of recommendation for the 140 over 90 in more general all-cause mortality reduction, cardiovascular risk reduction in general. That's what they say. And then if you're going to shoot for 135 over 85, this would need to be somebody who would be considered high risk for an MI specifically. Because they say if you kind of dig into the data with their review, is that it was primarily myocardial infarction that was benefited by the stricter control.
Mm-hmm. They say a 16% lower incidence with a number needed to treat of 137 over 3.7 years.
So with kind of like Mike said, what's the potential issue with going too low? Why does it matter? The side effects, of course, but also pill burden. So that's one thing that they reference as a hesitancy. Anytime you lower the goal, and the reason why clinicians might be hesitant to pursue these goals is because they say that sometimes it results in needing to add on extra medication. But we have we have studies that kind of talk about prescribing habits and evidence-based medications and doses that people are on, and it seems like there is a number of things that could be done for most patients to optimize. For instance, doses to max out some that highest tolerated dose before moving on to another, or using some medications that are more evidence-based that would hopefully prevent the need to add on an additional medication. Or at least you might be able to remove one, like, well, we're not using this beta blocker for anything but blood pressure. Let's take that off and put on maybe something that's going to benefit them more, lower the blood pressure more. They're not having an additional pill burden. We have them on more evidence-based therapy, and hopefully they get better outcomes over time. So there's obviously an interplay there But I don't think in every case, if you looked at it, that they would have to have additional medication.
Yeah, no, I agree completely. And so if looking back to 2018 in Circulation, there was an editorial published from Dr. Neil Skolnick, I think is how you pronounce his last name.
Nice.
Skolnick. And basically, it's entitled Icarus, Blood Pressure, and the Dangers of Flying Too Close to the Sun. So I feel like that's a strong stance to take. That's all right.
Somebody is a doctor, but they want to be a novelist.
Right. No, I respect. But yeah, I feel like that might be a little bit of a leap. But some dizziness or going into the sun, I feel like I'd pick the first option. But just to quote some of the things that he discusses, he mentions the fact that because not only the blood pressure goals changed, but also like the threshold for hypertension was lowered, and so the addition of 31 million people in the United States would then be classified as having hypertension that previously didn't. And then the other thing was that basically the risk of labeling, which does make sense. I hadn't really ever heard of it addressed in that way, but basically saying that he does quote some of the literature, but basically saying that individuals when they're told that they're sick, they begin to act sick, which, it seems like a huge generalization, but he says, that described in literature, blah, blah, blah.
I can buy that.
Yeah, I definitely could. I feel like that it's a big generalization to just say that the entire population is going to be like that, but I'm sure there's definitely evidence to back that up to some extent. But he said this is the phenomenon of labeling basically is concerning because with all these new people being now classified as being hypertension, like how many of those people are going to start basically having a nocebo effect of having issues. And so he does say that he does quote some studies here where he talks about some studies have shown that an increase in absenteeism from work and increases and physiological distress increases as patients are told they have like a number of disease states or a certain disease state. Mm-hmm. And basically say that there's a whole bunch of unintended consequences for the diagnostic criteria as well as the patients that are trying to shoot for these lower goals.
No, I'd imagine so. And I imagine that the labeling is in terms of finances, population health, with a lot of insurance companies having to pay for new medications that patients might not have been on, or follow-up visits more frequently that they might not have had to have. So I'm sure there's a number of arguments there. But I think when you get down to more of on an individual level and saying what's best for my individual patient, then you might look at it differently than, the population health thing.
And I think too, because if you look back at like the KDIGO guidelines that were updated for managing hypertension in a CKD patient, they actually have one goal systolic of less than 120 for some patients. But they have a whole huge section of a caveat talking about how are we getting that number, like how are we measuring that number? And they go through how many facilities, not just patients measuring their own blood pressure at home, but how many facilities do it incorrectly when they check a patient's blood pressure, which I've never, if you were to follow the actual step-by-step outline of checking a blood pressure, I've never had a nurse check my blood pressure correctly when I'm at a primary care officer or really anywhere. Yeah. I get rushed in from the waiting room, I sit down and I get my blood pressure taken, and that's it. Sometimes it's over my, it's like, and if it's high, they're like, yeah, look at that.
Yeah.
It's just like, okay. So I think that kind of going back to what Cole was originally talking about, like from being more patient specific, is one, we got to look at how we're actually measuring the blood pressure in the first place. And, are we doing multiple measurements? Are we we just going off the patient's home blood pressure measuring? There's so many different variables there in and of itself that can make a huge difference. The patient's using a wrist cuff versus an arm cuff. There's so many differences. They're using the wrong size.
Yeah.
And so, I think if all that stuff's not straightened out as a, kind of the foundation, then of course you're going to run into bigger issues when you're just throwing more meds on people's list.
Yeah, I think if you have concerns about the goal, then make sure that the blood pressures are being taken correctly. Patients check it at home to make sure that there's not wide-code hypertension, and then make sure their therapies are all optimized before adding something else on, or you will end up with side effects and poor outcomes, which of course there's not, just dizziness, and the elderly patients, we get concerned about falls and fractures and things of that nature. But for a lot of people, they would be mild side effects even if they did have them. But I can get on board with the fact that that would affect adherence and all that kind of stuff.
For sure. So I guess some practical, you started to talk about these anyway already. So some practical things that we've gone over many, many times as far as strategies and whatnot. Let's say you have a patient who their blood pressure is sitting at 140, or 145 over whatever, and we're going to shoot for a 130 over, or less than 130 over 80 goal. It's a more strict goal, according to the new guidelines anyway, and or an unfavorable goal according to the new guidelines. But it depends, like Cole was saying, what they're on at baseline. Are they on atenolol and other meds that we're not supposed to be using first line to begin with, and then we're just adding on to there? Like that's an issue. And I also think that that would potentially take away from the positive outcomes that the lower blood pressure goals could have if you're also on evidence-based therapy to reach those, because we know some obviously reduce the risk of mortality and others have not been shown to do that, or even in like atenolol's case, increase the risk. And I think if you have to assess, for instance, like we talked about the last episode about dosing of lisinopril, instead of arguing about nighttime or in the evening, if you need further blood pressure lowering, just split the dose it on the half-life, and optimize the dose anyway. And so like strategies like that, switching HTT and dapamide, I think Cole was talking about, you can kind of utilize some of these strategies without having to just say, okay, well, the patient needs to go lower, so we're adding on a bunch of medication. So, I mean, that's how I would look at it. I feel like guidelines in general are guidelines. They're
it's amazing
not
that there are so many guidelines, isn't there? Which obviously, this is a reference to very general guidelines for the general population. A lot of the other guidelines we talk about are diabetes specific or kidney disease specific or specific to something else. So these are general, but I guess which one you follow depends on where or what you practice in. I don't know how they decide which ones that they care about. I mean, we decide based on evidence and whatnot, but I guess maybe you look at this guideline, kind of like we do for UpToDate. You look at this guideline for a lot of other things, and so you also look at it for blood pressure and just kind of go with that.
Yeah, absolutely. And I think too, that's why it's so important to think of, like you were saying, like individualized patient, the patient-specific therapies, but also like keeping up with all of the different guidelines and things like that. Because even with diabetes, I pick and choose some of the stuff from different guidelines and kind of have made my own sort of algorithm just based on experience as I get more of it. And so I think that's another case of why it's so important. If somebody's just like, oh, this organization's who I'm going to go with, and that's just what I'm going to look at for the rest of my career, and it's setting yourself up for not necessarily being able to change and grow and adapt as a clinician.
Yeah.
The same guy that was writing that editorial in Circulation, I just want to read his last little his quote from the last paragraph where he's in conclusion, because he's going back to the Icarus poem. But he says the lesson of Icarus is that of hubris. Okay, don't use words like that.
Too much OUS.
Yeah, okay, come on, man. This guy doesn't want to be a writer, I guarantee it. So to be aware of excessive self-confidence. So again, it's a weird analogy, I guess. I'm so self-confident in my own ability for pharmacotherapy that I'm giving people medicine. I don't care if it gives them side effects. I know that's not his thesis, but I'm going to pretend like it is. Mm-hmm. He says to be aware that flying too high can interfere with flight itself. The lesson of the poem is that we should not be so focused on where we are going that we no longer see the suffering of those nearby. Okay, I can get down with that. He says for us in medicine, the lesson may be that prevention, when taken too far, may cause unnoticed illness of our own making. So basically, chronic care management and the whole preventative medicine, I mean, I feel like it's
might be causing more problems than we need.
Might be causing more problems. Spoken like a true hospitalist. I don't know if he is or not, but that would be hilarious.
This is a Circulation article?
Yeah. And then at the very bottom it says the views in this article are not necessarily those of
it's an op-ed. It's an op-ed in Circulation.
Yeah, that's funny. It literally says that in the footnotes. The opinions expressed in this article are not necessarily those of the editors of the American Heart Association.
Well, he's entitled to his opinion.
Yeah, of course. No, he's probably way smarter than I am.
Yeah.
So I mean, he's writing Circulation. I've never been asked. I've never been asked that even once.
Written in there, but we can. The great thing about podcasting is we can just say whatever we want about him, and
right. No, I'm sure
nobody has to publish.
I'm sure he's a nice guy. We'd have him on the podcast for sure.
No, I'm sure he's a nice guy.
Yeah, maybe.
I don't disagree with the thing he has in there.
Yeah, no.
It's just an interesting take.
Icarus was a good documentary. Remember?
That's a documentary.
And the one about, wasn't that what it's called, Icarus?
Wrong. 0 for 2.
What?
Yeah,
What's
I
it
was
called?
gonna let you slide on it, but
AJ, correct? What is it called?
It's like a tale. It's an ancient Greek.
No. I know
I know
the original story of Icarus.
Is there a modern thing?
Okay, first of all, AJ, you've already infuriated me. You've been
There's
back.
a movie on Netflix too.
Yeah, no, there's a documentary about the
thriller.
doping scandals that was going on with athletes and with cycling and stuff like that.
Oh, it sounds familiar.
Yeah, I'm like, he starts. Oh, it's actually Greek mythology.
Like, was this around the time of Armstrong?
I think it was after
that?
much, but the
Russians.
it was the Russian team.
Oh, it was
that
the
had gotten-
Russian team.
But they brought up Armstrong and a bunch of other stuff.
Performing though.
Yeah.
Interesting.
So, anyways, that was I didn't mean to go off on that tangent.
So that's our take on the new guideline.
Yeah,
It's
it's whatever.
yeah, it's whatever. It's fine.
It's a guideline.
It's a guideline, just like all of them.
So
So how about this next thing?
this next segment brought to you by Nova. No, I'm just kidding. It's not. But
Yeah, I heard about this in the news, and it seems like the people complaining about it are like rich people.
So here's the thing I don't understand, and I've never understood this. There's this attitude of like, I don't want to take, and I'm not saying that every single person who wants to lose weight needs to be on Ozempic or anything like that, but it's getting a lot of attention because Nova's pushing it because they know tirzepatide is going to be around the corner for weight loss and they're going to be screwed. But for now, they're pushing semaglutide. And it's getting a lot of traction. A lot of people are getting really good weight loss with it, at least, acutely. And I feel like there's always the pushback of people who are like, yeah, but that's cheating. Like, what? Like, cheating what?
Performance enhancing.
Yeah, like, I work at T-Mobile. What does it matter? I'm not who am I cheating? And I don't understand that mentality. Now, I get if you don't make lifestyle changes and things, it's going to be hard to keep up with the result. But I don't get where that attitude of like, nope, that's cheating. If it's not hard work, it doesn't count. Like, I guess, do you take antibiotics when you get sick? That might be classified as cheating then. But that's my ignorant 2 cents.
So what we're talking about is an interesting result of that people have complained about taking Ozempic and losing weight quickly, and that is that their face appears to be aging, right?
Yeah.
So
Ozempic face.
Some call it Ozempic face, but really it's just like wrinkles or excessive skin, and it's a result of the concern was the medication itself was causing them to age.
Yeah.
But it turns out that when you lose weight really quick and you have skin that doesn't keep up with the weight lost, then it's going to sag and it's going to look a little bit wrinkly. And it results in a Ozempic face. Yeah, I get on board with what you're saying. This article that kind of brought this, the reason we're talking about it today, the argument she would make would be that there are supply issues.
Absolutely.
There's supply issues, and so the medication should be safe for people who would fall in the obesity category or those with diabetes, is what she would say.
Yeah. Now, my one pushback to that would be, I don't think a lot of people realize that some of the big, like nationwide shipping compounding pharmacies can make semaglutide. They make formulations that basically are not available FDA approved formulations, and then they can compound semaglutide and
so you would suggest the wealthy people get it from there?
Well, like especially the ones that are complaining about access to it and stuff, and they're willing to pay exorbitant amounts of money. Like all these online telehealth clinics that are doing like semaglutide as far as, for weight loss off label, whatever you want to call it, they're using terms like Wegovy and stuff. They're all using the compounded version from those compounding pharmacies. And so like all of those types of places are getting it from that. And so they're charging less than it would be to pay cash for a brand name Ozempic anyway. Mm-hmm. So that's the part where I'm like, I don't know, if you're having a problem with it, instead of fighting with the pharmacies to get it, like go to one of these clinics that can get it, basically to you, just ship it to your house. So I mean, and there's a lot of them. I get spammed on Instagram for that, like basically daily. Like, and one of them was even pushing like, Ozempic, can't find Ozempic? Well, try this amazing weight loss medication. It's called metformin. I said, okay. If I paid $100 for a consult on telehealth, I'd be so mad. If he's like, all right, here's $500. You lose weight because you have diarrhea all day. But it's just like, there's so many options to get access to that. That's why I'm always a little confused why so many people are enraged at how.
Yeah, no, that's fine as long as it's not affecting anybody else from getting it. Though I haven't heard like specific instances of like individuals not being able to get it, but I'm not in the weeds on that as much. I haven't been in the weeds on that as much recently. But.
I've definitely seen like issues with getting it in retail pharmacies. Like I've definitely heard.
So if this was affecting that, then if it was for cosmetic purposes, that would bug me a bit. But if they've got other places they could buy it from, then yeah, the rich should do that. Well, I do think it's comical that if you're using it for cosmetic reasons, that it results in you having some wrinkles and that causes some distress. It just kind of makes me laugh a little bit.
First of all, Cole, that's mean. Second of all, it also is not everybody. So it's one of those things that patients, because there's a couple different things that can go on. Like Cole said, it can be rapid weight loss, but also you got to think that your body, in order to make collagen and elastin, you need protein, and if you're not consuming enough food, you're getting less protein in your diet, which is actually one of the big issues that a lot of people have that are doing like bodybuilding and things like that, because they'll also use Ozempic to like cut for those type of physique shows and things like that. But the problem is you can also lose a lot of muscle
because it decreases your appetite.
Right. And so you're not just cutting out your fats and carbs, you're cutting out your proteins and all that too. Plus you're not taking it. So you can get the loss of those proteins that, are involved with collagen production and all that. But then there's a potential for dehydration as well. So you're not taking in as much food or necessarily liquid. If you're just not have no appetite, you maybe not, unless you're one of those people that carries around the water bottle that tells you to drink don't you have one of those that tells you when to drink at certain times?
Gallon.
No,
I've seen them.
I carry a gallon.
Of course you do, AJ. Just all obnoxious.
You're one of those guys in the gym with a gallon of water,
and it's got like the colored yellow or blue, or like it's obnoxiously bright, so everybody knows you're drinking some kind of
neon
some
yellow
kind of pre-workout.
Gallon of water.
Yeah, I lift.
My doctor told me I had to switch to water from the gallon of milk a day I was doing.
Oh my gosh.
You were not drinking a gallon of milk.
I did it for like a week.
That's disgusting.
Put on 5 pounds.
I'm sure it was lean muscle too.
Though my wife's family growing up, they would buy like 3 or 4 gallons of milk a week. Their family could put down some milk. I know it's great. I mean, there's like 5 of them, but they can put down some milk.
I despise milk.
You don't like milk?
No. Never drink milk.
I mean, I do not like to drink milk straight, but...
You mix it?
Dude, give me some off-brand, Choco Dino Bites with some milk. Yeah, you start.
Right on.
You start. You start milky, and it ends up chocolate milk at the end. It's great.
Yeah, that's cool. That's a good point. I can't eat cereal because I'll just become obese, and then I'll need Ozempic forever.
I may or may not eat it twice a day.
No, that's good. And for you, I'm unfortunately
it's a guilty pleasure.
So old now that my metabolism no longer works. The other thing, like I said, dehydration obviously can lead to a patient being more prone to developing quote unquote Ozempic face. But it's also older patients as well. So, patients that are a little bit more, not necessarily, 65 and over, but, even 40s, 50s would be more likely than someone in their 20s. And then patients, perimenopausal patients and menopausal patients where they're getting this drop in estrogen already, they may be a higher risk for having some of that facial sagging, wrinkling than, a younger patient who's not, or is premenopausal. There's some people suggesting basically, which I'm actually, this is where you can see the entrepreneur kind of lights clicking, because some of the endocrinologists and things that are doing these type of consultations for weight loss and using semaglutide and whatnot, they'll partner with like plastic surgeon facilities that will just do fillers, and you just battle that Ozempic face as you're going. You one-stop shop. Very smart. But AJ, what are your thoughts?
I think we got to consider the role of SGLT2s and other medications that we use regularly, and
for weight loss.
Yeah, for those that aren't diabetic. I mean, there's hundreds of thousands of millions of pills out there. There's a lot of other options we could be taking for non-diabetic and non-obese people seeking weight loss.
I think it's the amount of weight, though. That's what's got everybody so excited.
It's the easy way out. If you want that, so those are options for providers.
AJ is one of those guys.
Yeah, you know what I'm saying? For providers that don't necessarily want to provide Ozempic for their patients.
Yeah, there are providers who have hangups about them.
I mean, and I've seen some that are like, well, you can do topiramate, or you can do the bupropion, naltrexone, the Contrave. But I'm like, yeah, but people are like Ozempic because of how quickly you lose weight.
And because of the limited side effects.
Right.
Topamax has side effects.
Yeah. I would never take Topamax just because I've seen so many people have that cognitive dysfunction with it. But, yeah, I mean, plus it's easy to use the Ozempic. And it's just one of those things that, yeah, I can totally get why the majority of people are wanting that versus other thing. I think tirzepatide, once that becomes available for weight loss, that obviously is going to blow Ozempic out of the water, I think. But I mean, people are losing a ton of weight with it. You can't really argue with that. I think the one thing to remind patients, if you are working with, patients that are dealing with Ozempic for weight loss, or semaglutide, I should say, Wegovy is the one that's FDA approved for weight loss. But encouraging patients to either meet with a dietitian or something that will help change their eating habits, because that's obviously the big issue with coming off of Ozempic is your appetite returns. If you haven't made changes in the choices of food that you're eating, you're going to just gain the weight right back. And some people gain back even more because now they're ravenously hungry.
Right.
And so I think that that's something to keep in mind. If you don't establish good, healthy eating and exercise, it's not, the weight loss is not going to stay.
Right.
But yeah.
That's Ozempic face. Soon it'll be Mounjaro face.
Yeah. I like that. It sounds like such a weird insult that if I said it, somebody real angry.
Hard Ozempic face.
Yeah, whatever, Ozempic face. They would just be so confused. I've heard of Ozempic. Why? It makes no sense.
What the adipose cells, they're their life cycle is 10 years, isn't it? So it takes 10 years for the adipose cells to actually die and go through apoptosis. So even if you do lose all
naturally
that weight,
or even with
naturally. So if you do lose all that weight, you're shrinking those adipose tissues. But as soon as you stop the medication, if it hasn't been 10 years, the tissues are still there. So they just continue to reinflate. So you never really lose the cells. The fat inside the cells goes away. But if you start eating again, you come off of it, they just reinflate.
But wouldn't, I thought part of it is because you're actually taking the beta oxidation or whatever, where you're taking fat and converting it into carbohydrate. That's where so it's not just creating apoptosis for those adipose cells. You're actually chemically changing them to be able to be used as glucose production.
Not the cells themselves, but the lipoproteins that go inside.
So you're saying the cell itself is then...
It's the storage cell is still there.
Okay.
So as soon as you start eating again, they're going to fill it right back up.
Gotcha. So besides, Ozempic, I guess, and you're going to have that same problem with anything. I think it's Ozempic just because you lose so much weight so quick that people notice it.
Yeah.
But
just do liposuction.
Yeah, well, that's cheap and definitely doesn't have any side effects.
Yeah, no side effects at all.
No, I mean, it's definitely interesting to see how things are going to be shifting. But to me personally, I think it's a cool option because I think weight loss is an important, especially in the U.S. is where, what is it, almost 60% of people now are overweight.
Yeah, so for those who need it, I think it is important.
Yeah. I'm going to give you some, Cole, see what happens.
I might disappear.
Maybe it'll have the opposite effect.
Yeah, I just gain a lot of weight.
Cole's just shredded when he comes back on. All right, what's these potatoes?
Yes, so I won't belabor this, but this is my favorite topic of the three. And sadly, I do this every time, but I can't log in and access the full article at the moment. But so I'll tell you what I remember about it. But the reason I came across this, and I feel like we've been bashing Medscape a little bit today.
To make the record clear, I love Medscape.
Yeah, Medscape has some good stuff, but they obviously put on some op-ed opinion stuff we don't always agree with. So
do we.
Yeah, we do too. So we'll give you our opinion on it. This one was written by, quote, Medscape staff. So at least I'm not calling anybody out in particular. It's just a very quick article, so I'll give you the high points of it. But then they cite this article from the Journal of Medicinal Food that was put out by the Louisiana State University's Pennington Biomedical Research Center. But the title of the article is "Eating Potatoes is Healthy." So you would imagine that that's a pretty, if I saw that, which I did, I clicked on it because I'm like, wait a minute, I like potatoes and I want to be healthy, but generally I consider potatoes unhealthy for all the different reasons that, you can imagine. So the article says, contrary to common belief, potatoes do not have a negative effect on blood glucose levels and can actually help people lose weight, according to this study, which I was like, I'm going to have to take a look at this study. So they put a few bullets of what to know. So they say potatoes are filled with key nutrients packed with health benefits and do not increase your risk for type 2 diabetes, as has been assumed. They say that's a fact. They say people tend to eat the same weight of food. So I thought this was interesting. They eat the same weight of food regardless of calorie content to feel full. So by eating foods that are heavier in weight and are lower in calories, you can reduce the number of calories you consume. They go on to say a number of other things like potatoes make you feel fuller more quickly, that patients who are overweight, obese, with insulin resistance, that their blood glucose levels were not negatively affected and they lost weight. And they also said people don't generally stick to diets and you can prepare potatoes in a number of ways and they're inexpensive, blah, 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 blah. So I'm like, I'm going to have to take a look at this study. So this is why anytime you see any article, especially when it's medical, it's best to look at the study. Because looking at this, I would walk away thinking, hey, potatoes are great. I'm just going to tell everybody, potatoes are great. Let's just all eat more potatoes. But that is not what this study says. So it is a relatively small study, though very interesting. There's only 18 patients, and it was over 8 weeks. And essentially, they modified their diets to give them a diet that was not primarily, but a significant portion of it was potatoes. And they compared it to a group who had a significant portion of pulses, which are basically beans, dried beans, a type of dried beans that you obviously boil, or I think they said lentils. Like I said, I don't have the article pulled up now.
What a weird diet.
So the reason they did that was because there's been studies, multiple studies, that show that beans, a diet heavy in beans, compared to a control, produces better glycemic outcomes. And then you lose weight, and it's just overall a good thing. And so that's why generally we consider beans to be kind of a healthy protein, though a bit, maybe starchy.
Yeah, it's still starchy though.
A little bit starchy type of vegetable, but overall, in terms of getting some protein and stuff, we consider beans to be healthy. But in general, potatoes are classified as not being healthy because they're high in starch. Now, the basis for thinking that potatoes could be healthy is that they are considered a food that is low in energy density. So what that means is the calories to weight ratio is low. So a low energy dense food is considered 0.5 to 1.5 kilocalories per gram. Potatoes are about 1 kilocalorie per gram. So as you can imagine, for the amount of weight a potato actually is, though high in calories overall, compared to how heavy it is a bit lower. So that's why the idea of, people generally eat the same weight in food. So if you can get a heavier food that has a relatively lower number of calories compared to its weight, then maybe this could be a beneficial thing. So that's kind of the basis for it. The Medscape article says you can prepare potatoes however you want to, and it's going to be healthier and whatnot. If you look at how the potatoes are prepared, so there's also been other studies looking at the way potatoes are prepared and how that affects your glycemic index. And it seems to be pretty compelling that if you boil up potatoes, mash them up, and eat them, you're going to have a more significant spike in glucose than if you boil them up, put them in the fridge for 24 hours, and then eat them as leftovers the next day. It seems pretty compelling that for sure you're going to have less of a spike in glucose because there's something that happens when the gelatinized potato is cooled overnight, where it gets more resistant starches. That's what they call it. They call them resistant starches, abbreviated as RS. And so they have a higher ratio of resistant starches after they're cooled, and those take a little bit longer to digest than if you hadn't have cooled it. So if you look at this article, they compared the bean diet to this potato heavy diet, but the potatoes had been cooked and then cooled for 12 to 24 hours and then given to the individuals. So that seems like a pretty distinct difference between what I would imagine just saying, eat any potatoes you want and they're healthy. No, it has to be leftover potatoes. So they could have titled the article, Eating Leftover Potatoes is Healthy. And I think that would have been just as clickable as eating potatoes is healthy. Now, here's the question I had. Did they serve the potatoes cold? I'm not going to eat cold potatoes, okay? So they cited 4 articles talking about how these cooled potatoes is going to have more resistant starches than the freshly prepared potatoes. And it's interesting to look at. But they compared a group of patients or people, well, first it was like the same group, but first they would eat freshly prepared hot potatoes, and they would take blood. And then they would eat potatoes that had been prepared, boiled for 30 minutes, quartered, left overnight for 24 hours, and then they would give it to them. Of the 4, only 1 specified whether they were served hot or cold, and they were reheated. So I imagine hopefully that even in this study, they did reheat the potatoes, because who wants to eat cold potatoes? But for sure, I think it seems like cold potatoes might be reasonable. But then hopefully also reheated potatoes might be reasonable. So anyways, you can look through it, and even the data is not super compelling that even if it was leftover potatoes, that for sure it's like 100% healthier or whatever. But there is a possibility that if somebody was really liking their potatoes, you can tell them, hey, cook those potatoes, pre-cook them, put them in the fridge for 24 hours, eat them as leftovers, and it might be a little healthier that way.
Unfortunately, from like a scientific mindset, that actually makes perfect sense.
Well, that's not unfortunate. That's fortunate.
It's fortunate for the doctors, but not for the patients.
Right. You're right, because I don't want to eat leftover potatoes. But maybe if it's between cutting, like having to do like significant portion control and really cutting my amount of potatoes, or maybe considering eating leftovers, maybe I'd do that. Now you might ask the question, AJ, how did they prepare these potatoes? Did they do mashed potatoes? Did they
leave the skin on?
They leave the skin on. So they do specify the skin was left on. Mm-hmm. But were they mashed is what I want to know, because I like mashed potatoes versus quartered. Or were they stuck in the oven? Were they fried? What they do? So it sounds like skin on, boiled, quartered potatoes is the way that they did it. Leave them in the fridge overnight for 24 hours, and you have a better glycemic outcomes compared to if you mashed them, or of course, if you fried them and salted them. So I had the question just looking at the title of the article. Well, can I eat French fries? Can I eat potato chips? And is all this healthy? No, because you have the oils, you have the salts, you have those other things. But it sounds like boiled potatoes, cooled, and then reheated possibly, quartered with skin on, might be not as bad as the alternative.
Did they have a potato salad arm?
They did not. But listen, in one of the studies, this is funny that you mentioned the salad, in one of the studies where they were just looking at how the potatoes were prepared and how that affected glycemic index, one of the arms had potatoes that were boiled, quartered, cooled for 24 hours, and then they added a vinaigrette to it. And it actually was had a little bit better results than no vinaigrette, which was odd. But yeah.
So about the science, man.
That's a literal potato salad.
The science. It's the starches will cross-link at cooler temperatures, and then the enzymatic hydrolysis requires more energy to break down those bonds for absorption. So you technically would get
so it makes sense. So that's that's what the question I had about reheating. So would reheating just undo the whole process?
It wouldn't undo it, but it'd take away from the energy required for your body.
So pure cold would probably be better than reheated, but maybe reheated is better than fresh.
Right. Like water. When you drink cold water, it takes more energy for your body to absorb it.
Right.
Yeah. No, that makes sense.
That's why I always drink scalding hot water.
Yeah.
You know what's crazy about that? If that's the takeaway is in order to eat these potatoes to the quantity that people are insisting that are willing to do all this, you have to eat cold potatoes and you have to do all this preparation. I'm like, yo, we gotta get you new food. That's what the moral of that story. You like potatoes too much.
I do really like potatoes, and they specifically used white potatoes, or I guess russet potatoes. But they do look at. There was another study where they compared different types of potatoes and things to see. I didn't look much into that, but they even have looked at that and how that affects glycemic index.
Were the patients in the study you're talking about, the newer one, were they patients with diabetes or pre-diabetes?
In the trial with the beans versus control, it was specifically diabetes patients where they showed better glycemic outcomes, weight loss, insulin resistance with the beans versus control. In this one, it was not obese, but overweight, greater than 25 BMI, with insulin resistance that they looked at, that they found with a HOMA-IR test or something. I didn't look into what that was, but they were supposedly classified as having insulin resistance and being overweight. And they actually lost weight in both groups, which you can imagine would happen because they have people preparing the foods. It's almost like being on a diet. But
I mean, if I have a personal chef, I'm gonna lose weight.
Exactly. But the main takeaway is that compared to the beans, with both groups having prepared meals, that the potatoes did not have worse outcomes.
So what's funny about that is that makes complete sense to me, because everybody assumes, like you said, beans are more healthy because they've been compared to placebo. I pulled up a couple examples. So when I'm talking to my patients with diabetes, I use Calorie King if I'm trying to assess carb content of certain things. So refried beans that are canned, basically 1 cup, you're talking 39.1 grams of carbohydrates. It does have 13.4 grams of fiber, so some of those carbs are complex, carb fiber, and there's also 13.8 grams of protein, which is nice, but still 40 grams of carbohydrates. But even then, that's not outrageous, even for someone.
But that's why it's important to specify, because these were dry beans or lentils, not refried. So
pinto beans, would that count?
I guess what is a dry bean? I don't know. If it's in a can with liquid in it, is that not a dry bean?
I think it technically would still be a dry bean.
Okay. So as long as it's not refried.
So I'll pull up lentils then. So boiled lentils, 1 cup, you're talking 39.9 grams of carbs, so it's even more carbs, and then 15.6 grams of fiber. 17.9
So
grams
fiber counts, though.
So
yeah, it does.
The fiber does count. And so what they did was the way that they prepared the meals was in a reasonable fashion, carbs to protein to fats. And so they weren't having, so it is obviously always about portion control.
Yeah.
So they didn't have excessive portions of carbs or anything. So it was like an equivalent amount of carbs from beans versus an equivalent amount of carbs from potatoes. But what you're saying is beans aren't necessarily just like greatly healthy.
Well, and just to give you some comparison with potatoes, and this is like a raw potato that has the skin still on.
Mm-hmm.
1 cup of like diced up potatoes would have 26.2 grams of carbs and only 3.3 grams of fiber. So it makes sense that obviously there's less complex carbs in here, but there's still less carbs overall. And if you're still eating a total of 1 cup for a consistent period of time, well, you're getting less carbs. So
right.
That seems like it would be less things. Plus, there's less fat in a potato. There's only 0.1 grams of fat in that 1 cup versus like with where's the lentils? With lentils, those are really lean as well. But the refried and pinto beans, I mean, they're gonna have a little bit more. I think refried probably is the most, 2.2 grams. So I mean, they're gonna have a little bit more fat content. I feel like that makes sense that potatoes did better. It's interesting though because
or
they're
equivalent.
But there's a Medscape article from 2015 that I found with this really in-depth Google search that I just did while Cole was talking. And the title of this one is Potatoes Tied to Higher Risk of Type 2 Diabetes. French fries are the worst. Now that's a title.
It's amazing.
But their whole breakdown was, and they included like 70. It was basically a cohort that they were looking at, combined data from 3 cohort studies, 70,000 plus women from Nurses Health Study 2, and then men from the Health Professionals Follow-Up Study.
Yeah, I think that 70,000 is a little more than 18 that was in this study.
Yeah.
I think I'm glad you pointed that out about the beans, because I think what I ultimately take most issue with is the fact that, apart from you, most people, even if you're like looking up like healthy eating, would consider beans as healthy. That's usually included on more of like the healthy diet spectrum. And potatoes are almost exclusively included on the less than healthy spectrum. So I think they're both kind of middle of the road, just depending. So I think that's good.
I think it's alpha glucosidase, that the starches are not built the same. And kind of like Mike was saying, the complexity of them, the fibers will still try, the alpha glucosidase that we produce will still try to break down those fibers, but can't. So they're pretty much just like, they're distracted in the GI system as they go through the upper, the small intestines. Mm-hmm. I was going to say the upper intestines, the small intestines.
It's the first intestines.
Yeah, the first one, but they're like distracted or they're not being able to act on the other carbohydrates. So it's kind of just like taking away, it's like a negative carb almost. And that's relative still even. Yeah. It's not healthier by any means.
Did you call him Michael?
I will now.
It sounded like you did.
Michael,
I
what do you think
about it? I was like, "Are you my wife? Am I in trouble for something?" That's when I get called Michael.
I said Mike.
Either my mom or my wife's yelling at me about something. No, but I mean, it's definitely interesting, and I feel like my thing when I'm talking to patients is like when they do like baked potatoes, for example, I always tell them, "Yeah, good, go have one," but just put that in your carb pile. Yeah. The big thing is, and just also what do you put on the potato? Because especially here in South Carolina, you got to check that because people are like, "Oh, I have a baked potato, I'm super healthy," and you're like, "Yes, but they put on," and it's the most loaded you could ever.
Well, that's how I like. I mean, everything but sour, cheese, butter, salt, bacon bits. Woo. I don't even care if it's true. Like,
dude, those better not cost extra.
Well,
if you make it yourself.
Well, here Anna, well, of course I didn't make it myself, but Anna likes to make actual bacon and then bit them onto the.
Oh my god!
I'm like, that is extra.
You guys spend too much time.
I'm fine with buying the store-bought bacon bits in the bag. That's fine with me, and I will eat them straight out of the bag.
I'm fine with leaving them in the bag too. I do not like bacon on a potato.
Oh man,
I like a little thing of butter, and that's that. Maybe some sour cream.
No salt.
No. I eat the worst like bland food you could ever imagine.
We know.
It's bad.
We know.
I don't season nothing.
Not a bland
If you want food, if you want me to cook anything, you're not gonna like it.
I'm a salt fiend. It's not good.
We'll get you started on some amlodipine.
Preventatively. Just preventatively.
But that's kind of interesting. It is funny though because I was literally saw that the other morning, like walking up to to work, and I was just looking at stuff through my emails, and I saw the same thing. I was like, potatoes, and of course I clicked it.
Yeah, it doesn't. It's funny because I just talked about it forever, and it doesn't mean much. It's not like anybody's going to change much about it, but I still thought it was interesting.
Yeah, no, it was good. I could tell that. I could see that. That's the most passionate I feel like you've been about.
It's mainly it's mainly the fact that the Medscape article did not point out that they had to be cooled overnight, but then also the idea that you could cool them and there might be some benefit to it.
Yeah, that is good to point out all around. I like it.
Yeah. Yep. I didn't click it because I knew that already.
Thanks, AJ.
Yeah, cool.
Well, we educated everyone but you.
Except AJ.
I eat potatoes every day.
Do you really?
Every day. Literally every day.
Yeah. You didn't have any potatoes. Oh, I guess your French fries that you had when you got here were potatoes. That makes sense.
But they're Chick-fil-A, so they're healthier than most regular potato fries.
According to this article from 2015, French fries are the worst.
Anything in a waffle shape is healthier. That's why waffles are healthier than pancakes.
Exactly.
That's true.
Study for that.
No, it's not.
I was going to say, I feel like there's not a study that proves that.
It's on the Prevagen website.
Yes.
Yeah. Oh, man. Brought to you by Prevagen. Anything else, boys?
That's all I got.
All right. Well, I guess that'll conclude this first episode of what's happening now on our Medscape emails. But so thank you guys for listening. Hope that wasn't too all over the place. I enjoy stuff like that though, because it's less. I feel like it's less serious. Yeah. Not that we're ever that serious, but I feel like we can really, whatever. Anyways, thank you guys for listening. If you do want more serious and structured lectures, obviously check out the Patreon, patreon.com/coreconsultrx. The link will be in the show notes. If you have any questions for the three of us, you can reach us in the emails that are in the show notes, or you can reach us on any of the social media platforms. Send us a text to the number in the show notes as well if you want to do that. I have a few people that I need to respond to tonight. So again, if we don't answer you right away, I promise we will get to you as quick as we can. But maybe not as quick as we can, but as quick as it's like
as quick as
convenient. Yeah, there you go. I'm just trying to keep it honest.
And, we're not going to let it stress us out.
Right. I do sometimes. I'm just like, oh no, they're not going to listen to us anymore. But if you guys have anything, let us know. We'd love to hear from you. And we will see you guys on the next one. Have a good night.